Hello, my name's Roger Henderson and I'm a GP in southwest Scotland, and I also co-host the GPnotebook study groups. So welcome again to this GPnotebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. And you can find us wherever you get your podcasts, including Spotify, Apple Podcasts and Google Podcasts. But do please follow us to receive notifications about new episodes. And if you're liking what you hear, do please consider leaving a review to help other listeners find us. It really does help. You can also follow us on Twitter at GPnotebook for more information about new podcast episodes and study groups, and you can visit GPnotebook.com for podcast episode show notes and to find out more about upcoming study group meetings. Now, in this episode, I'm going to take a quick dive into colorectal cancer. And one of the reasons for this is a really fascinating study that's just come out in the Oncology Lancet journal. And this looked at colorectal cancer incidence trends in younger versus older adults. And this looked at the year of diagnosis, sex, and 5-year age group for 50 countries. And temporal trends were visualized and quantified and stratified by age at diagnosis, and average annual percentage changes were estimated. Now, previous studies had shown that colorectal cancer incidence was increasing amongst younger adults, in other words, below the age of 50, in multiple high-income Western countries, in contrast with stabilizing or decreasing trends in incidence with older adults. And this particular study aimed to investigate contemporary colorectal cancer incidence trends in younger adults versus older adults. And it did indeed find that early onset colorectal cancer incident rates are rising in 27 of 50 countries examined, with the rise either exclusive to early onset disease or faster than the increase in older adults in 20 of the 27 countries. And these findings do underscore the need for intensified efforts to identify the factors driving these trends in younger people and to increase the awareness to help facilitate the early detection of this often devastating disease. Because let's not forget, bowel cancer is the third most common cancer worldwide and the second highest cause of cancer death. And here in the UK, it's the fourth most common cancer after breast, prostate and lung, and there's around 11% of all new cancer cases here linked to it, with about 44,000 cases each year. Now, although the incidence does appear to be increasing in younger people, the actual rates are still highest in people aged 85 to 89, with about 40% of all new bowel cancer cases in the UK being diagnosed in people aged 75 and over. Proximal colon tumours are more common in women and older people, whereas distal lesions are more common in men and younger patients. Now, the risk factors that we're looking at in colorectal cancer is a complex interaction of genetic and environmental factors. But after age, family history does seem to be the most common risk factor. And so with individuals with one affected first-degree relative, their relative risk of developing colorectal cancer is about 2.2. And this increases to just under 4 with 2 affected first-degree relatives. And we mustn't forget family cancer syndromes too, such as Lynch syndrome and familial adenomatous polyposis, because these are associated with 2 to 5% of all colon cancers. We now know the impact of obesity on a huge range of cancers, and this does increase the risk of developing colorectal cancer, as well as being associated with a greater risk of dying from the disease, with high calorie intake and physical inactivity probably being synergistic risk factors in its development. And we also know that a high intake of red and processed meat is a risk, and there's also some evidence now to suggest that high carbohydrate intake might increase the risk of colorectal cancer in men. And many studies, although I have to say not all, do show an inverse relationship between dietary fibre intake and colorectal cancer risk. A few of the others to consider include things like cigarette smoking, significant alcohol consumption, and low levels of vitamin D. Now, the most common presenting symptoms and signs of cancer or large polyps are rectal bleeding, a persisting change in bowel habit, and anaemia. And the presentation in our patients does tend to depend on the site of the cancer. So if we look at right-sided colon cancers, typically we see weight loss, anaemia, occult bleeding, sometimes a mass in the right iliac fossa, and unfortunately the disease is more likely to be advanced at presentation. With left-sided colon cancers, we often get colicky pain, bowel obstruction, an early change in bowel habit, sometimes tenesmus. There may be a mass in the left iliac fossa and less advanced disease at presentation. And between 6 and 10% of patients with iron deficiency anemia will be found to have colorectal cancer, most commonly on the right side of the colon. Most patients with right-sided colorectal cancer are anemic at diagnosis, but renal function is typically normal, except if there's advanced pelvic disease where the ureters may be compressed. I'd also remember that LFTs might be normal even when liver metastases at present, and I've seen patients with huge liver mets with normal LFTs. A FIT test should now be offered because this does have a high degree of sensitivity, but a previously normal bowel screening result shouldn't give reassurance. So we should always be looking to do a FIT test if colorectal cancer is suspected. And NICE advises to use a FIT test to guide referral for suspected colorectal cancer in all adults with a change in bowel habit, or an abdominal mass, or iron deficiency anemia. It also suggests we do it in patients aged over 40 with unexplained weight loss and abdominal pain, or under 50 with rectal bleeding and either unexplained abdominal pain or weight loss, or over 50 with unexplained rectal bleeding, abdominal pain or weight loss, or 60 and over with anemia, even in the absence of iron deficiency. Now, if you suspect you have a patient with colorectal cancer, then complete examination of the colon is indicated. And a flexible sigmoidoscopy may be entirely appropriate in a low-risk patient, such as a younger patient under the age of 50 with an isolated rectal bleed. But a crucial point here is that if a malignancy is detected on flexible sigmoidoscopy, it's vital that a full colon visualization is then undertaken either pre or post-operatively, because synchronous cancers occur in around 5% of patients. Now, if you've got a patient who doesn't want to have a colonoscopy for whatever reason, or they're not suitable candidates, then either double contrast barium enema or a virtual colonoscopy, CT colonography, does provide an endoluminal view of the colon similar to traditional colonoscopy, and it does have equal sensitivity to conventional colonoscopy in the detection of colorectal cancer. Now, we often test for CEA levels in primary care, but really this should only be measured after confirmation of the diagnosis, because CEA testing as such is not sufficiently sensitive or specific to be used for diagnosis in symptomatic patients or as a screening tool in our asymptomatic patients. Now, many patients are routinely followed up with CEA testing to detect colorectal cancer recurrence, but the evidence does suggest that CEA is insufficiently sensitive to be used just alone in this setting. Although positron emission tomography, or PET, is valuable for detecting recurrent colorectal cancer, it does have little effect on its staging. And NICE guidance does state now that testing for Lynch syndrome should be offered to all people with colorectal cancer when first diagnosed, and this is by using immunohistochemistry. We use TNM classification to stage our colorectal patients. And I'm not going to go through those in any great detail, but if you look at the show notes that accompany this episode, this will give you more information about this, should you need it. When you've done TNM classification, you can then further stage it as stage 0, stage 1, stage 2, and stage 3 and 4. And again, these are in the show notes. Now, the management of colorectal cancer is complex, and it depends on a myriad of factors, including patient personal preferences, the staging and grading of their cancer, any comorbidities that may be present, and local availability of services. Now, in 2022, NICE updated its standards on colorectal cancer treatment to include all adults with a new diagnosis being tested for Lynch syndrome. Adults with a diagnosis of early colorectal cancer should discuss the implications of all potential treatments with their specialists. That adults with metastatic colorectal cancer who should be suitable for systemic anti-cancer treatments should undergo genetic mutation testing. And adults who have undergone potentially curative surgical management of their non-metastatic colorectal cancer should be followed up for 3 years to look for local and distant disease progression. Now, surgery still remains the definitive treatment for localized colorectal cancer, but both radiotherapy and chemotherapy can improve survival rates after potentially curative surgery. Now, minimally invasive surgery using hand-assisted laparoscopic or robotic techniques is increasingly used for colon cancer. And in most circumstances, it's now preferred to open surgery given appropriate expertise being available. Now, after apparently curative resection, NICE recommends a minimum of 2 CT scans of the chest, abdomen, and pelvis in the first 3 years, and regular serum CEA tests that are organised and reviewed by the colorectal oncology team. Radiotherapy is also an established treatment for locally advanced rectal cancer, but as we know, it has significant adverse effects, and there is a range of opinions out there on its risks and benefits in individual patients. Now, about half of people diagnosed with colorectal cancer survive for at least 5 years after diagnosis. 60% of them are amenable to radical surgery, and 70% of these will be alive 7 years later. Survival rates relative to age-matched groups without colorectal cancer are 45% at 5 years after diagnosis, and the good news is that survival rates in the UK have been rising steadily over the last 3 decades. 5-year survival rates are about 90% for people with localized cancer, just over 70% for people with cancer that's spread to regional lymph nodes, and about 15% for people with distant metastases at diagnosis. So I hope that was a helpful reminder about colorectal cancer and what we should be looking for when considering the diagnosis in our patients. But do have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you consider following the podcast and leaving us a review on your favourite podcast platforms. Do get in touch via social media at GPnotebook or email us support@GPnotebook.com if you have any questions, comments or ideas for future podcasts. You can also visit us at GPnotebook.com to register for our virtual GP Notebook study groups, which occur all year round and have a huge range of topics each year, and to download free shortcuts to help improve the lives of our patients in primary care. But as always, thank you for listening, and until the next time, goodbye.